Good afternoon, everybody. First things first, can everybody hear and see me okay? Okay, good. I'm going to go ahead and jump in. Thank you so much for joining us this afternoon. My name is Michelle Reese. I'm the president and CEO of the North Carolina Institute of Medicine, and you're joining my organization and the Duke-Margolis Institute for Health Policy for this timely conversation about how non-medical drivers of health in North Carolina can help promote affordability in our system. So before we jump into our content today, I just wanted to give a little bit of context about NCIOM, a little bit about context about our partnership with Duke-Margolis. So we really work with our sister organization to explore health policy around the state. We host learning events such as this one and others, and we really work together also to translate evidence into policy guidance, both for state legislators, for local elected officials, for health system administrators, and for other stakeholders, depending on the topic that we're looking at. Several of you that I see who are attending today have participated in our North Carolina Institute of Medicine Legislative Health Policy Fellows program. This is a program that we're currently in our 5th cohort of. We've been running it since about 2018, and it really serves as a health policy orientation geared toward new state legislators, making sure that you all have the information and the data and the resources that you need to make decisions about the health of people in our state. And we really, just seek to help connect you with that data, with those resources, and with those people who can be helpful to you when you have questions. So before we move on to our panels today, I did want to give a little bit of context about today's event. So as you know, North Carolina has been an innovator in addressing non-medical drivers of health in our state. These drivers include things like food, housing, transportation, and we've invested in these ways in order to invest in health rather than health care. And one of the things that we're going to highlight today is the Healthy Opportunities Pilot program that ran through July of last year. And a little bit of context on that program. So the Healthy Opportunities Program, also known as HOP, was originally approved as part of North Carolina's Section 1115 waiver under the first Trump administration in 2018. And this program really required setting up a new infrastructure for the state to link previously siloed systems of care across 3 predominantly rural regions in our state. And really to provide 29 different types of services to eligible Medicaid members in 4 key domains. And those domains were housing, nutrition, transportation, and toxic stress. The Healthy Opportunities pilots, the way they were organized were around 3 network leads, one in each of those regions I mentioned. And those network leads managed a network of community-based organizations in their area. And these organizations were the ones that provided those services, housing, nutrition, transportation, and toxic stress services to those eligible Medicaid beneficiaries. And then they were able to invoice the Medicaid system for those services and use allocated Medicaid funding to pay for those services. As we're going to hear from our panelists today, HOP really demonstrated value for improving the health, infrastructure, and economies of North Carolina's communities. And even though that implementation of that program was paused last year due to ongoing state budget negotiations, we know that there are a lot of partners across the state who are continuing to learn from that program and figuring out ways to preserve and adapt its core components, recognizing that it is really a part of a broader set of efforts in our state to address these non-medical drivers of health and to promote affordability and better health outcomes for the people in our state. So we are really excited to bring you 2 panels today to talk about these questions more. Our first panel is really going to be focused on a look back at the lessons from implementing HOP, and the second is going to look forward to new opportunities in addressing drivers of health. Once we go through those 2 panels, we're going to have time for Q&A and discussion. We really would like to encourage you throughout both of the panels to put your comments and questions in the chat. You don't have to wait until the end to do that. We've got folks on our team who are going to be monitoring that chat, and we'll bring those questions and those comments to our panelists at the end. We're going to try to get through as many of those questions and comments as we can today. If there are things that we don't get to, we will make sure to follow up with you with some answers either from the panelists or or from our teams pulling together some additional information for you. I also just wanted one little housekeeping note. We are recording today's session. We are recording the panels, but we are not going to be recording the Q&A. And if you don't see it turn on and off, that just means that we're going to be cutting that Q&A section after the fact. So don't worry about being candid or sort of saying what you mean. We're not going to have that on the recording of the final version. So I'll pass it now to Dr. Mark McClellan, who is director of the Duke-Margolis Institute for Health Policy, and he's going to provide some additional opening remarks and context for today's discussion. Thanks so much. Over to you, Mark.
Hey, Michelle, thank you. And thanks to the North Carolina Institute of Medicine for your leadership and collaboration with us in addressing these important healthcare challenges together here in North Carolina. I want to say hello to everybody who's joining us today. I want to thank all of you for your leadership and efforts on these issues as well. I'm Mark McClellan, as Michelle said. I'm the director of the Duke-Margolis Institute for Health Policy, where our mission is really all about improving health and the value of healthcare through practical, innovative, and evidence-based policy solutions. And Michelle said it, but you all know it. We are living in a challenging policy environment from the standpoint of these issues, with real fiscal pressures at both the federal and state level, real issues in terms of access and affordability, but I also think some new opportunities and opportunities to build on leading programs that have worked, in some cases have started and been adopted more widely from their origins right here in North Carolina. And there is some continuing bipartisan interest, as we see from participation today, on how to make healthcare more prevention oriented, how to pay for health and staying healthy, how to address the root causes of poor health so that we can improve outcomes while reducing healthcare costs, not just paying for those medical complications. At the state level, thanks to the leadership and ongoing support and engagement from the North Carolina General Assembly, this state has been a national leader in moving healthcare in this direction. Programs like the Healthy Opportunities pilots and the North Carolina Integrated Care for Kids programs have tested these innovative approaches to better align healthcare, prevention, community-based supports to address the non-medical factors that are important here, to build out more sustainable approaches to helping North Carolinians stay healthy and live healthier lives. We've had a significant federal partnership in this approach to help get the most bang for the buck, since a lot of federal dollars go into these Medicaid programs and eventually, as people get older, into Medicare as well. As we've seen, and as we'll talk about today, these programs are demonstrating meaningful impacts on health outcomes and on reducing medical costs through targeted community-based approaches that integrate health care, and the social care, the social supports that are so important to affecting the health and well-being of North Carolinians. We're going to talk about some of the independent evaluations that have shown improvements in health, reductions in medical spending on the order of $1,000 per enrollee per year, especially through, again, well-targeted to the individual and the family, evidence-based services like food and nutrition supports. And the findings also show the potential for greater savings as these programs are refined and get better targeted over time, that rely on better data, artificial intelligence, better support tools to get the best outcomes at the lowest cost. This all can provide a foundation for continued progress, translating the longer-term health and cost benefits into addressing the near-term budget challenges that we're facing today, is what we want to talk about today. How we can build on stronger data, ongoing real-time or close to real-time evaluations and adjustments with continued learning, with direct involvement of healthcare of clinicians, healthcare providers delivering services out there around the state, with engagement from health plans, with engagements from community organizations, and some of the experts and analysts who have been working with these programs as well. It's really a team effort to continue to learn about how we can help support better health, in ways that keep getting more effective, efficient, and sustainable. At the federal level, there are new pressures and opportunities as well. Most importantly, the Trump administration and the Centers for Medicare and Medicaid Services, under their current leadership, have signaled a commitment to continuing to advance these well-targeted prevention-oriented reforms, as Michelle said, started out as innovative programs in the first Trump administration. There are some new developments here too. As the Make America Healthy Again agenda has emphasized, it is really important to get our chronic disease rates and burdens down in this country, starting with all the kids, many of whom are getting their care through Medicaid, their families, for people with disabilities, for our older patients with complex conditions. There is so much we can do to intervene earlier and help them live better, healthier lives in the community and address some of the root causes of costly healthcare complications. We've got years now of foundations of improving data systems across our social programs, our medical programs, and improving insights from these early pilot programs and waivers to do better. On top of that, the Rural Health Transformation Program funds, $213 million per year to North Carolina, will support, with President Trump and the administration's direction, innovations involving digital health, technology, better data systems, and new and innovative ways of delivering needed care to underserved rural areas, ways to address these root causes of disease. So the new innovation center models accompanying these rural health transformation programs are also designed to do this, again, with a real focus on both finding the best innovative ways that the community and with the private sector innovation to deliver better care and making sure it translates into lower healthcare costs as well. And in all of this, we're going to be paying clear attention to the changes that are coming under H.R. 1. These are Medicaid program changes that, through better information systems and the like, can help make sure that Medicaid benefits are going to people for whom they're intended, and all of those people, and new attention to the Medicaid waivers nationwide to make sure, just as we're really focused on here at the state level, that we can implement innovations that really do save money over time and that keep getting better over time. There is growing evidence from these programs in North Carolina, a number of others that are moving in the same direction across the United States, that show how well-targeted, efficient approaches for identifying people at rising risk and families at rising risk through knowing them, having trust, being engaged in their communities, can help them make changes in their lives that help them get to better health through medical and non-medical steps like better nutrition that lowers hospital utilization and leads to the overall cost savings we need for bending the cost curve and getting to sustainability of our healthcare systems. The great thing about being here in North Carolina is that we have such a strong foundation of health plans and healthcare providers, community partners, our elected leaders who are actively working to find ways to bring down costs and help North Carolinians stay healthier, avoid these poor outcomes that are making our health system unsustainable. North Carolina has helped lead the nation in these important issues. That leadership is especially called on in these challenging times. From a budget standpoint, where on the one hand, we need to find better ways of delivering care, and on the other hand, we really know that keeping on doing the same old thing in our healthcare and in our chronic disease risk is just not going to work. So at this critical moment, we really appreciate all of you coming together and rolling up sleeves on how we can build on what we've done so far to identify, implement, and scale approaches that advance whole person health and do it while getting the most out of our state and federal dollars. The North Carolina General Assembly's leadership is obviously going to be critical to ensuring that these efforts continue to demonstrate impact, accountability, and sustainability, that when we continue to implement these programs, there will be monitoring and building on these kinds of evaluation approaches along the way to make sure that they are staying on track in terms of improving outcomes and reducing costs. That's going to keep us in the front of the nation and for the benefit of North Carolinians, implementing programs that are really effective in meeting the challenging times that we're facing today and building on the work that we've done together so far. So I'd like to get that going right now by turning to our first panel, and Ayana Simon, I think, is going to kick that off for us.
I am. Thank you so much, Mark, and thank you all again for joining us today. I'm Ayana Simon. I serve as the Associate Director here at the North Carolina Institute of Medicine. And fun fact, I was part of the implementation of healthy opportunities at Carolina Complete Health. So near and dear to my heart. So joining us at our first panel will be Dr. Seth Berkowitz, who is Associate Professor of Medicine, at the University of North Carolina at Chapel Hill. His team has led the evaluation of the program. Sarah Ridout, the Director of Community Programs for Community Care of the Lower Cape Fear. They served as a network lead and are still very involved in the community, what that looks like now. We also have joining us Brandon Wilson, who is the Chief Operating Officer for the Asheville Buncombe Community Christian Ministry, ABCCM for short. And they've done some excellent work as a community-based organization, or HSO, within the pilot, and then also still continuing to do that work as well. So thank you all for joining us and giving us some of your experience and insight to the program, to the pilot, and where we go from here. So as you all know, as Michelle indicated, 2018, we started this path forward in North Carolina to figure out how we really address some non-medical drivers of health. And for us, it was through the Healthy Opportunities pilot. So I want to just hear from our panelists on what that looked like. So I'm going to go in the following order. So I'm going to ask Dr. Berkowitz first, Sarah, and then Brandon. Looking back over the past several years of HOP and what you know about it from your perspective, what do you see as some of the most meaningful impacts? Feel free to touch on any of the implementation in your organization, what that evaluation looks like, and anything you might, do differently or what you think might be ideal for future state. So Dr. Berkowitz, I'll start with you from the evaluation standpoint.
Sure. Thanks so much for having me, and excited to talk with folks today. Sorry, getting over a bit of a cold. So yeah, I think there were a number of impacts to HOP that are important to talk about. And just to sort of situate it in context, I'm part of the independent evaluation team. We have completed and submitted to CMS. CMS approved and has made public what's called the interim evaluation report for HOP that covered the first half of service delivery. And then we are currently in the midst of preparing what's called the summative evaluation report that will look at HOP service delivery over the entire first demonstration period. So going from when it was first approved up until the end of 2024, that'll be submitted to CMS this spring. And so in the evaluation, we looked at a number of different impacts that HOP may have had across different categories. And so just to highlight a few of those, we first looked at the ability of HOP to reduce the risk factors that often drive poor health, things like food insecurity or housing instability and things like that. And we found that HOP was effective in reducing those risk factors. People came into HOP because they were experiencing them, but those risk factors declined in HOP participants. And when compared with other people who likely would have been eligible for HOP but lived in parts of the state where HOP services were not offered, those risks declined faster in HOP participants than they did in other folks. And so we interpreted that as an impact of the HOP program. We looked at the impact of HOP on health outcomes and participant experience, so people's health-related quality of life, depression symptoms, various chronic disease measures, and in general found positive impacts for HOP in terms of improving health. And then we also looked at areas of healthcare utilization, like inpatient hospitalizations, emergency department visits, things like that. And in particular found that HOP reduced emergency department visits And then finally, we looked at sort of how all that came together in terms of healthcare spending. And what we found was a pattern that was expected, but was good to document and quantify in the study. And that is basically that the time that people enroll in HOP is one of high healthcare spending. People are often enrolling because they've had an emergency department visit or because they've been hospitalized. And so that immediate period when people enroll, healthcare spending is high. But then if you follow people, you see a decreasing spending trend. So spending is going down. And importantly, by using a comparison group, we're seeing that the spending is going down faster in the HOP group than it is amongst people who are not in the HOP group. And so that lets us estimate what we think would have happened had people not had access to HOP services. And our estimates are that spending decreases much more quickly than it would have in the absence of HOP, likely because it's able to prevent things like emergency department visits by improving health and reducing these health-related social needs like food insecurity and housing instability. And so it kind of all came together into a picture of addressing some of these factors that put people in situations where they're less able to be healthy. And in fact, these situations often undermine the effectiveness of the regular medical care people are getting. So when people get regular Medicare that's paid for by Medicaid, if they're not in a situation for it to have its full effect, they're not able to, say access healthy foods or those kinds of things, then the effectiveness of that healthcare may be diminished relative to a circumstance where people have it. And so it seems like HOP is kind of putting people back on track in that way. That's obviously a very sort of high level, big picture thing. It's obviously always very important to keep the perspective of the actual beneficiaries in mind. And so I know the other speakers on the panel will do that, but I kind of just wanted to set the stage in a big picture sense.
Thank you so much. And to your point, we're going to drill right down into that local level. So Sarah, I'm going to go to you next, if you don't mind answering a question from your perspective as a network lead.
Yeah, absolutely. So, Dr. Berkowitz already talked about, of course, what HOP was designed for, right? So, showing that proof of impact on health outcomes and healthcare costs. And we saw that locally as well. So, not only did we collect regional data, but we also had member stories about, lowering A1Cs, managing asthma exacerbations, so different things like that. But what we also noticed in terms of just impacts really did end up going beyond health. So, for example, we had school counselors share that children or their families receiving HOP services actually had more consistent attendance in schools. We had care managers share because we did a big survey after the pause to really understand what HOP looked like for them and how useful those tools were. But care managers really had a reliable, vetted set of tools that supported their ability to meet care plans, reduce crisis calls, and increase patient engagement, which we did see reverse when the pause occurred. So, and again, I can certainly go into detail on that if anybody is interested. One thing I think is just so interesting is this collective impact around health plans and clinically integrated networks and these community-based organizations really breaking down silos. Because if you think about, for example, a lot of these CBOs, they're going after the same philanthropic dollars. They may be doing duplicative work. You don't have that in this type of environment, right? You actually have that collective impact and you have different stakeholders kind of coming together in ways that they never would. I always had to laugh because we would see health plans, which typically, aren't sharing best practices kind of at the end of HOP, actually making sure and really helping each other across different plans, which was really very interesting. And then I think finally, one thing we saw again in terms of just impact beyond the outcomes that Dr. Berkowitz talked about is we did have economic and local resource impact. So that was a huge byproduct of the pilot.
Awesome. Thank you. And Brandon, I'm going to jump right into you. So ABCCM is boots on the ground in the community, providing those services. Tell us about what you all are seeing as impacts of HOP and maybe the pause as well.
Well, I can't say it better. Sarah just said a lot that I think she stole from my mind just now. So I appreciate that, Sarah, from your point of view. For us as a faith-based nonprofit in rural Western North Carolina, I think the biggest impact it had, I think, for not just my organization, but for other CBOs, is we leveled up to a place of operational maturity that we never would have gotten to if it had not been for hops. And the ripple effects of that operational maturity included, standardizing some of our definitions of what outcomes should look like in alignment with our healthcare plans, in alignment with our MCOs, and it just solidified and grew relationships that we didn't have, not only with other CBOs and partners, but it made us a part of a bigger solution for healthy outcomes. By now, it really forced us into that space, right? Out of our comfort zone of just knowing what we know, and now what our role is into the broader and the greater healthcare ecosystem based on just doing what we were doing, right? You take the direct services out of it, and we, at the height of what we were doing, we were feeding nearly 1,000 families a week. Another 200 we were supporting with housing through the program. But what that did for us in our infrastructure was allowed us to grow and to scale in other areas that HOPS wasn't in, that allowed us to reopen our dental clinic at our free medical facility, right? We would not have been able to do that and build that infrastructure if HOPS wasn't there. So, I mean, there's so many different layers and ripple effects of why HOPS was so successful outside of the great work that Seth and his team did and the direct services. It was the economic factors, the economic impact it made to a community, organizational capacity, community capacity. I think those are things that oftentimes we forget about. And if I had one thing to share with our legislative friends who were on the call, is it wasn't just about what's in the evaluation report. It's these other facets such as saving family farms that may not be in the report and be codified, but actually improves the mental health and behavioral health of an entire community. And so just to echo on what Sarah and Seth said, maybe that's from my point of view, that was a big, big impact that we saw.
Awesome. Thank you so much. So I'm going to stick with you, Brandon, and ask you. So we talked about some of the positive impacts. Let's talk about some of the challenges. What would you say were some of the challenges, and how did you all, kind of really face those and address them?
Well, I think something that we ended up doing successfully, but we weren't prepared for at the beginning, was the level of scale. As an organization of our size that we're already in this space, we were already feeding families. We knew that, hey, we could do this really good. Let's start with what we know really, really well. And we went from, 200 families a week to 800, 900 families a week that we were feeding through HOPS. And it was like, oh, crap, right? And our great partners at Impact Health were really able to help us with capacity building funds. But the money's only one thing, infrastructure is the other, right? And so we had a very steep learning curve to be able to get to a level that was appropriate for the size of our organization and the size of the community that we were caring for. So scale was a huge challenge early on that we were able to overcome with our partners. I think the other end of that infrastructure was the financial part of it. I think North Carolina did it right in the fact that you had these network leads that were able to help take the burden off, including our PHPs, that took the burden off of Medicaid eligibility for CBOs. Because if you'd have told me we had to determine that Medicaid eligibility from day one, I don't know if we could have done what we did, right? Other states are actually enforcing CBOs to do that, and I think they're not going to be as successful. So our network leads, our PHPs, our MCOs were a vital part of that success, and allowing our CBOs and leveraging organizations like mine to really do what we do really, really well. So I would say scale was probably the biggest challenge and infrastructure, but we were able to overcome that pretty quick because of the design of the program.
Awesome. And as a network lead, Sarah, you all have had to pivot your organizational infrastructure as well. What are some of the challenges you all face with either implementation, delivery, et cetera?
So yes, so during the pause, one thing we wanted to do is look, is there something that we can do regionally to help support some of this work? Because we did see a lot of gaps from our care managers and the care managers that had participated in the Healthy Opportunities pilot. So, like I said, we had done a survey as soon as it paused, and just to kind of share some statistics, which anybody who does a survey will be thrilled with this number. We got a 43% response rate. So, just going to go say for a survey, that is absolutely huge. But out of those that responded, care managers, 79% reported that they were unable to resolve their SDOH goals because of the lack of resources available. So that means when HOP went away, we still had the same resources in our region, right? But they're already maximized. And so 79% of those care managers said that they were unable to fulfill those particular goals. About 56% reported that they were spending more time on member support calls, including crisis level care. Okay. And then another 64% reported that members were disengaging from their care and their health plans, either frequently or very frequently. And we actually have that report available. It's on our website. But again, just to share that when the pause occurred, we still have resources in our region, but we were finding care managers were already struggling in this particular space. So just again, Ayana, just to say, what are we doing here regionally and what are some of the things we're looking at? I think Brandon said one thing, hit it best around the invoicing and reconciliation piece, a lot of those financial pieces for our CBOs. That was a really big challenge. But again, this was proof of concept, right? We're taking what we've learned, we evolve the process. So I think one thing that can be done moving forward is you can see network leads potentially centralizing some of those administratively heavy burdens for organizations participating. So I think, again, some of these things can be very easily remedied by a hub model where you can centralize some of that stuff. And that includes even contracting with different health plans.
Yeah, I think that's a good point of one of the wins of the organization. So Sarah, still going to stick on you for a little bit. You are looking at it more from a regional approach, right? So that the region, that HOP region as a network lead, you have visibility to. Can you talk a little bit more about the impact to the communities that were being serviced? Brandon spoke a little bit about it. What about from your perspective as a network lead in some of those in multi-counties?
Yeah, absolutely. So, again, I think I spoke to several of the impacts kind of, earlier, but I did just, I think it's really important to emphasize that HOP really does have a greater impact than the outcome measures that were set, right? So, all networks, and that includes, I see, Laurie Stradley here with Impact Health, and then I see Tina Dixon on the call from Access East, the three network leads. We're all going through an economic impact analysis just so we can really show what the true impact was in our regions. And so far, I can only speak for our region. And I think Laurie's going to maybe speak to this later. Very, very positive. So just in our 6 counties alone, HOP generated around $59.6 million in additional ripple effects on top of direct program spending. So that is also a contribution to the local workforce, building skilled labor for these community-based organizations. Brandon really spoke to that as well. But also your subcontractors, right, in your rural communities that are modifying homes for safety, your local farmers producing the produce that goes into boxes, or your local businesses providing materials. And then just another impact, but just a little bit different, is actually after HOP ended or paused, I was sitting next to the community risk reduction coordinator for the Wilmington Fire Department in a random housing meeting. And she kind of came to me and she said, when HOP ended, their emergency response needs increased, right? Because now those folks that were getting those preventative services and having those in place are now relying on emergency response. And so that's our fire department, right? That is our ambulances. So there is also impact on those emergency response resources in our communities.
Yeah. I think that's a good call out on how it is just like the overall community impact. I'm going to take it back to Brandon. So you talked a lot about the need to scale and the organizational operations and things like that. Can you talk about a little bit more about what that looked like? Partnerships that you all created, financial sustainability, now that the pause has happened. What did that look like during the pilot? And what does that look like now for you?
Yeah, well, one of the things that we learned and we've actually went to and applied and are now implementing is the value and the importance of measurement and evaluation within your own system of care and how it relates. And so we've took a very strong and forward approach to doing more measurement and evaluation of our programs and how that aligns with the larger healthcare system, right? So if we did it internally, because I think it's a good idea, it don't matter. It takes people like Seth and partnering with people like that to make you understand what actually is creating healthier outcomes for the community. So measurement and evaluation is one of those pieces. And I'd be amiss to say we just recently published a playbook for measurement and evaluation for a care coordination model that is addressing the SDOHs through Northwestern University from a hub model, from a coordination center model. We've been operating in that space in the veterans capacity with NC service for a decade. But now what HOPS exposed to us was we've got to do a better job of telling that story. And so back to that operational maturity that I mentioned earlier of pretty much where we are going and moving forward with. And so partnerships include those with United Health and Blue Cross Blue Shield. Like we never had partners. I wouldn't in a million years I would have thought of we would be partnering with those two entities. I specifically say those two because we work with them the most often through HOPS. But now that's went into other opportunities for partnerships and for funding for CBOs through larger healthcare plans that would not have existed if it had not been for HOPS. And so we're carrying that momentum and carrying that forward along with our measurement and evaluation piece. I would say on a funding and sustainability level, we are now taking a way more strategic approach of how, as a nonprofit and a community-based organization, we set ourselves up for sustainability outside of just being so heavily reliant on grants. Right. And I think most nonprofits always struggle with that. But what those partnerships have done is exposed the opportunities and the windows and the doors that we could walk through or creep in to create a more sustainable structure for the programs that we're providing.
Awesome. Thank you so much. Mm-hmm. So Dr. Berkowitz, I'm going to come back to you. In your evaluation work, right, HOP was designed to test whether addressing those non-medical drivers really are going to reduce costs. You talked a bit about that cost savings, those early indicators that we're seeing that have said that the program was effective. So what would you say were other additional learnings so far about the services or populations that have the greatest opportunity for bending that cost curve? And is there any more evidence that you feel like is still needed?
Yeah, I think those are great questions. So, what we've presented or reported so far has been the interim evaluation, and so I think the summative evaluation will give a more complete picture of spending, not simply looking at the trends, shortly after enrolling in HOP, but really looking over the entire period and kind of going month by month and estimating those spending things. So there's definitely more to be done. I think it's also important to note that, the HOP is really a program to improve health, and when healthcare spending declines, that's because people get healthier, right? So healthcare spending can go down in a couple different ways. People could just stop getting healthcare even though they need it. That would reduce healthcare spending, but is likely not to improve health. But that's not what happened with HOP. What was happening in HOP is people had less need for expensive healthcare services like emergency department visits and those kinds of things. And so that I think was very good to see. In terms of do different clinical populations or things like that benefit differently? we surprisingly to date have not found evidence that there's a lot of what we call heterogeneity, variation in the response to HOP. I think it is expected that that would be the case, and it certainly makes sense. Not everyone is going to respond exactly the same way. But I overall have been surprised by the consistency of the response against different, across different, not against, across different patient groups, in that we see pretty similar impacts. No matter what populations we look at. Now, part of that is because HOP was designed specifically to only enroll people who were very likely to benefit. So it is not that all Medicaid beneficiaries were able to get HOP. They had to have both clinical criteria across a number of different categories and have social risk factors as well. And so there's already a lot of selection and targeting that went into even being able to get services in the first place. But once once patients sort of made it through that, we honestly have to date seen that the impacts are pretty similar across all of those different groups, which suggests that the enrollment criteria were well chosen, and it's not that there are some groups who get a lot of benefit and some groups who get no benefit or anything like that. It's been fairly consistent across the different groups, or what we might call homogeneous.
Awesome. So it sounds like we have a couple of reports coming that we can share, right? Summative report. Sarah, it sounds like you all are working on the economic impact. Brandon, you all have a paper at Northwestern. If you all don't mind sharing that with us, we'll make sure to share all of those resources out too. And thank you all so much for all of the work that you've done as a part of the pilot, and then everything that you're going to continue to do within your organizations to keep that momentum going in the communities that you serve, with all the lessons that you've learned from the pilot on how to really address some of those non-medical drivers and just improve overall health. So thank you all so much. I am going to turn it over to Rebecca, who's going to take our next panel, and then we'll have some question and answer a little bit later on. Thank you all so much.
Great. Thanks, Ayana. And good afternoon, everyone. Thanks for joining us today. I'm Rebecca Whitaker, and I'm a research director at the Duke-Margolis Institute for Health Policy. Really appreciated the discussion of our first panel, Seth, Brandon, and Sarah, and in particular, highlighting some of the innovations coming out of HOP, as well as some of the challenges. And I think in particular, the comments around sort of this broader community impact, as well as the way in which all these different players and partners came together, from the community-based organizations, the network leads, the prepaid health plans, clinically integrated networks, and really kind of creating and implementing this model, and using Brandon's words, like helping each other kind of level up here. So really appreciated that. For this next panel, we'll discuss how we can build from the lessons learned from the Healthy Opportunities pilots, North Carolina Integrated Care for Kids, and similar initiatives in North Carolina to both inform future interventions and strategies to address non-medical drivers of health, with the goal, again, of improving health and reducing healthcare spending. So our panelists are going to describe some of the innovative ways that they're addressing drivers of health through their organizations, and how these approaches can inform a shared path forward. So excited to introduce our panelists today: Laurie Stradley, who is the Chief Executive Officer with Impact Health; Tom Friedman, who is the Executive Administrator of the State Health Plan, part of the North Carolina Treasurer's Office; Colleen Briggs is the president of the Blue Cross and Blue Shield of North Carolina Foundation; and Rashina Chalera, who is the executive director of North Carolina Integrated Care for Kids, as well as an assistant professor of pediatrics at Duke University School of Medicine and core faculty at the Duke-Margolis Institute for Health Policy. So thank you all for joining us this afternoon. I'm going to come first to Tom and to Colleen as folks who are connected with the payer and purchaser side of these discussions. So Tom, over to you first. If you could talk a little bit about the state health plan's motivation for addressing non-medical drivers of health for its members, and how do you think about evaluating whether these investments are delivering value, both in terms of health impacts, but also in terms of cost containment, some of those broader economic impacts?
Thank you, Rebecca. Can you hear me okay?
Yes.
Awesome. So I think the biggest area we're focusing on in terms of non-medical drivers of health, we're starting with food as medicine. One, I think it's an area we can directly impact, and I think aligns with the Treasurer's values around economic development in areas. I think North Carolina has some of the best produce and agriculture in the country, so we want to be able to highlight that for our members and really the importance that can bring to different communities and making sure there's resources within communities. How we think about evaluating it is kind of a couple-fold. And one, I would say our prevalence of hypertension and diabetes is both near about 20% of our membership, and about 70% of our membership overall have at least one physical or mental behavioral health condition. So we have folks that need additional support. And if we look and see our folks on average go to the doctor somewhere between 1 and 3 times a year, so call that 2 hours, 4 hours of their time, however you want to think about it. There's a lot of time that they're not at the doctor. So providing community-based resources where we can to help them with those conditions that they have all the time really seems kind of fundamental and core to what we're doing. Short term, how we're looking at it is the reduction in emergency room utilization. So there's some good research we found that better food, better nutrition leads to lower emergency room utilization in the short term. So kind of a short term win, both from the spend perspective, but also more from the member experience point of view. How we think about it in the long term, it is probably a little bit based on our folks managing their conditions better. We're partnering with a couple groups to, in addition to provide food resources to the western part of the state, also looking at how are folks doing monitoring their blood pressure, how are they doing at measuring their A1Cs. So some of those kind of clinical byproducts of eating better and having better access to food is going to be really, really important. And I think the hypothesis in the long term is that should help manage spend. Right. So right now we're spending somewhere between $50,000 and $25,000 a year on a lot of our more chronic members. So it doesn't take a big kind of percentage impact to have big meaningful dollars when you're talking about the amount of money and the amount of people here. And in a lot of cases, it's also an economic motivator of keeping people in state government, state employment, right? Like if you feel more seen, better served, you are more inclined to stay, which gives us a longer window to help invest in improving your health, right? If folks are transitioning every year, while it's the right thing to do from a human point of view, it's maybe not necessarily the right investment to do. We're very, very lucky. People in North Carolina are teachers and teach for a long time, and we cover them for a really long time. And state employees are really, really dedicated people who serve for a really long time. So we have the opportunity to do right by them for a really, really long time. So it's actually, I would argue, it's a bad investment to not put money into some of these programs and resources to make sure that they're seen and cared for. And so we hope that will create better partnerships and better member engagement as we're kind of seen doing the right thing. Because as we ask them to do more to improve their health, I think it's a foundation of you should trust us because we are doing these things on your behalf. We're trying to help rather than being the big bad insurer, which I think a lot of people are rightly skeptical of.
Yeah, I really appreciate that and kind of thinking through this just strategic decision making that you all are doing at the state health plan, and starting with food as medicine and thinking about how creating access to healthy food and nutrition can also enable some of those other changes that you're talking about around better, chronic disease maintenance and lifestyle changes that can kind of ensure those trajectories stay pointed in positive direction. So Colleen, coming to you for a very similar question. I know you all are thinking a lot about food as medicine as well. And so what is Blue Cross of North Carolina's motivation for these investments to address non-medical drivers of health, and how are you measuring some of the impacts of these investments?
Yeah, so our mission is to improve health and well-being of our customers and communities. And the one thing that just keeps coming up again and again with our data is that if we don't invest upstream in these non-medical drivers of health, we will not be able to bend the cost curve. For all the reasons everyone said, we're going to keep paying more for these kind of preventable problems when they're more expensive. And so actually, I think the example that was just shared is a perfect one. Diet-related chronic conditions are one of the largest, most addressable cost drivers. It's expecting to cost the state something like $65 billion over the next 5 years, but very often the care starts too late. So many of these kind of diet-related chronic conditions could be better managed or even prevented with lifestyle changes like better diet. But by the time treatment begins, we're often behind both medically and financially. So that's why we have made some significant investments that really try to move upstream. How do we try to solve some of these medical challenges before they start in a way that can improve health and reduce costs? And so we are particularly focused on how do you improve health through food? And we do it by helping people, build healthier habits. So we host teaching kitchens in our neighborhood centers. The second is that we're actually trying to scale some of these food as medicine programs into the healthcare system. think we're one of the only payers in the country that offers no-cost food prescription programs paired with nutrition coaching. And for our members with uncontrolled type 2 diabetes, again, commercial members. And what we've seen is significant cost savings and health improvements for those kind of programs. We see improvements in physical well-being, mental well-being, improvements in blood sugar levels, improved confidence, and importantly, cost savings. So we're seeing, an improvement of $139 per member per month in total cost savings from those kind of programs. We also source the food locally, and so that also helps some economic benefits as well that we're able to track. Importantly, we also try to think, you can't just sort of ask people to eat healthier, but without access to healthy food. So we are partnering with farmers and local groups to get access to healthy food that's local food. And all of these programs, we do have some pretty rigorous evaluation around it. And what we continue to find is improvements in health outcomes, lower costs, like you just heard with that program, and just overall a system that is really working better, where it's trying to get to some of these issues before they become a problem. And one thing we're going to start doing more going forward is actually sharing these kind of insights going forward. So we just launched our first report on SNAP benefits, and we enrolled some of our members into SNAP, and we just studied what were the impacts, and what we saw: improved health outcomes, but also 3-to-1 cost savings. So again, what we're trying to do is release more of this data publicly, so it's not just us being able to benefit, but where others can also see what's working, what's not, and then partnering with groups like the Shep Center and others on learning about different programs, and where we can, do everything we can so that everyone is starting to also learn from some of these insights and continue to share and learn from each other.
Yeah, absolutely. That's really great. And I think we'll add to our list that Ayana rattled off earlier in terms of great reports and data that we can be referencing as we continue to sort of learn from the experiences that you all are having in implementing this and evaluating what's working and really targeting your investments. So I'm going to come to you next, Laurie, as somebody who, the Healthy Opportunities Pilots is a Medicaid program, but we're hearing from Tom and from Colleen, this is really a multi-payer strategy that folks are building across the state. You were thinking about similar things at Impact Health, but really from an implementation perspective of how do you take a multi-payer strategy and implement that as a kind of community care hub and network lead. So if you could talk a little bit about what do you see are some of the benefits of a multi-payer strategy, and how can these types of financing models really support that long-term sustainability for efforts addressing non-medical drivers of health?
Thanks, Rebecca, and thanks for including me in this. It's so much fun to be on a panel with all these brilliant folks. When Tom and Colleen are talking, I'm jotting notes just like the rest of the audience, but I really appreciate this conversation. So at Impact Health, we came into being to support the Healthy Opportunities Pilot, which was really a first of its kind. Yes, other 1115 waivers across the country had dabbled in social care integration, but we tested out 29 services across 4 pillars to support our Medicaid members. And that made it incredibly unique and gave Seth and the team and others the opportunity to really peel back all the layers to figure out what's going to work best. And so with all of that opportunity behind us and hopefully also ahead of us, we've had the chance to drill down so that I can have a conversation with a payer about a specific pain point or a specific population that they're struggling with engagement or program participation, or even ultimately employer groups that are wanting to keep their employees healthy and well retained, recruit well. There are just so many opportunities to talk about the way that this works best. And one of the reasons I think that, having an initial investment from a government payer, they are often the largest payers in the country and have the greatest drive for innovation that is going to bend the cost curve because so many folks are there. But then that gives us the opportunity in the private sector and with both business and service support and private foundations to make investments in very defined ways. Rather than this big picture with 29 services, we can drill down and figure out, depending on where you sit and what your business or programmatic demands are, how do we make those more fine investments? And so, for example, right now we are working with one health plan, one practice, and narrowing in on our high-risk pregnancies. We know that those are some of the most critical intervention points for lifelong health, not just for the time of pregnancy and postpartum. But because we know about transportation issues, because of our work with Healthy Opportunities, we can refine exactly what and how much our healthy food boxes are, deliver them to the individual, and then stay in touch with them through our care management models. We're actually trying to drive increased engagement with care management, because there's a huge amount of data behind the idea that an individual experiencing high-risk pregnancy will have better health outcomes if they're highly engaged with their care manager. They're more likely to get the right care from the right provider at the right time. And so our 2 or 3 year investment looking back allows us to refine the way that we engage and invest and really use our healthcare dollars for healthcare purposes. I think all of us here wish that we could eradicate hunger overnight or solve the housing issues, but that requires blended and braided funding as well. And when we're specifically talking about healthcare dollars, we need to be working together for healthcare outcomes and have to be more intentional with how we put those together. So it is about hunger, but it's about the clinical behavioral health outcomes associated with hunger that allows us to use these healthcare investments and then plug in all of the other pieces at a time. And just the last piece I'll add about the braiding the public and private funding is that it's very much like the rest of our healthcare system. We need to all be engaged in this because we trade members back and forth all the time. Today, they might be a part of Medicaid. Tomorrow, they're going to be employed with someone who has a Blue Cross plan. And in 2 years, they're going to be a state employee. And so if we make better collective investments in the systems that allow for coordinated and integrated care, we're going to have a better long-term outcome overall, and we're going to bend the curve for regional, state, local, national healthcare spend in a way that benefits all of us.
Yeah, I really appreciate that point, and I think maybe I'll use Brandon's saying again from earlier, like how can we all work together and really level up, given this kind of interconnected nature that you're describing, and I appreciate the point too on sort of the critical nature of care management as a mechanism for connecting families and kind of continuing that relationship. So Rashina, I will use that as my segue over to you. North Carolina Integrated Care for Kids is a multi-payer care model for eligible Medicaid kids and families operating across the 5 different Medicaid standard plans, and has been able to generate some really promising evidence on how to reduce expensive healthcare use among participating kids. And improve family well-being. A big piece of this, of course, is your care management model. So can you tell us a bit about the Integrated Care for Kids program, its approach to supporting kids and families, and the work that you've been doing to really assess those health and spending impacts over the 5-year course of the pilot?
Yeah, thanks for having me. I'll echo Laurie that it's really exciting to hear about everyone else's work on the panel. I don't, I'll start a little bit with a little bit of background on NC Inc. or NC Integrated Care for Kids. So for those who don't know, the Inc. models are CMS demonstration models. So the CMS Innovation Center supports innovation models to test different ways to change how we deliver healthcare and pay for healthcare. And the Inc. models are the only pediatric model currently that CMMI is supporting. And North Carolina has had one of these models since they were released back in 2019. So the model has been now ongoing for about 5 years, and we're in 5 counties in central North Carolina. And we have about 100,000 eligible Medicaid enrolled kids in those 5 counties. So what NC Inc. does is the entire model really takes this preventive approach that everyone's been speaking to. So how do you think about the upstream drivers that are not just clinical, but also, of course, the social and contextual factors, and especially for kids, most of whom are healthy, how do you identify kids and families who may benefit from additional supports early to prevent the healthcare spend that we are often putting a Band-Aid on. And so the way that we do that is through integrating data systems. So we've been able to integrate, of course, healthcare data. So we look at things like ED utilization and diagnoses, but we also look at guardian data. So we take a two-generation approach. And so we know if a child has a guardian with substance misuse, that is a risk factor for that child, not just for the guardian. Similarly, we've piloted things like looking at WIC and SNAP enrollment because those are household factors. Those don't impact one individual. We bring in data from school systems, so we're able to look at school absences. If a child has missed, 30 or 40 days of school in the past year, that's a red flag that says, oh, this child, this family might benefit from additional support. We also look at child welfare involvement and juvenile justice involvement. And so all of that data comes together at the state level and is integrated. And then the Medicaid plans, and as you said, Rebecca, we have all 5 standard plans participating, get a risk score that comes out of that integrated data. And that then prompts care management outreach. So either the plans themselves or the health systems that are the primary care providers for children in the model are doing outreach to families to engage them in our care model, which is a longitudinal care model. So it's not often care management has been, 30 to 60 days of support if someone's, used the emergency room more than would be expected. But this care model really takes the approach of let me understand what's driving the risk factors that we're seeing. Do you need support in navigating the, getting developmental services for your young child? Do you need support in actually enrolling in SNAP because you've been denied and you don't understand how to figure out that application? So much more holistic long-term support and whole family support. So again, it's the household, it's the caregiver, the household head that's eligible for things like SNAP. So taking that approach of if we can get families enrolled in SNAP and WIC, that's going to benefit the whole family. And we've had some really promising results. A big part of our approach, as you have alluded to, has been really careful, regular, iterative evaluation. So we've been constantly tracking things like engagement. And so as all of you doing this work know, engaging kids and families and things like care management can be really challenging. Everybody who's eligible does not engage. And so iterating on that with the systems that are working with us and with the payers who are working with us has been a really important part of how we've done the work and how we've developed innovative new systems and referral pathways. And the last thing I'll add is Laurie alluded to this, but being able to bring the health systems and the payers together in one space and present data that says, hey, look, this integrated data does a really good job at helping us figure out who are the right kids, who are the right families at the right time. And we can target the supports better, but we need to brainstorm collectively to figure out how we do this coordination better. And those conversations have driven a lot of the innovation we've been able to get to.
Yeah, and kind of bringing the partners together to think through, what is the best approach? What is the most effective and efficient way to address family needs and really drive toward health? So really appreciate that point. I'm going to ask one more question and I will direct it to all of you. And that is, we've been talking about the Healthy Opportunities Pilots, Integrated Care for Kids, other programs and initiatives that folks have built within their own organizations or are plugged into in their own communities. If we are to think about a whole state strategy for bending the cost curve, what do you think are some consensus areas for investment to work toward that? And how do some of these initiatives to address non-medical drivers of health really fit in? I don't know if anybody wants to start, or Laura, you're first on my screen, and so I can just popcorn according to the order that you guys are on my screen.
Sure, I'm happy to start. And this conversation comes on a really interesting, exciting day. The RFA related to the rural health transformation, the first RFA in North Carolina to help us get this up and running. And, I think that's going to be an exciting way to continue this path, and there's deep recognition in North Carolina's application that the move towards whole person integrated care that recognizes the impact of social health is critical to rural health transformation. And so with that, I hope that funding will be very targeted around the infrastructure that allows us to provide better coordinated care in rural spaces. But that doesn't deliver the services themselves. So ideally, this investment will bring down the cost of delivery and the cost of evaluation so that we can continue to use other funding streams to deliver the right service at the right time at the lowest cost. And so I am optimistic that we'll see things like a more targeted version of Healthy Opportunities come back to life in this short session as we start to think about the ways that we lean into what's working and augment what's coming. And one of the things I'm most excited about with rural health transformation infrastructure is going to be that data integration that Rashina was talking about. We've got to do a better job sharing across sectors and communities to be able to have practice and individual level plans for support all the way up to a state level coordination that allows us to do the work. And we can't do that if we have 140 different data streams that don't talk to each other. So I'm optimistic that we're committed right now to investing in that. And it's going to take more than rural health. It's going to take other sources of state funding, private funding, partners like Blue Cross and Duke and the state health plan all coming together to get this done.
Yeah, so hearing sort of this multi-stakeholder partnership, the rural health transformation infrastructure dollars, data, certainly, as Rashina was alluding to, kind of the ability to identify folks that we may not elevate for some of these services if we're just looking at their healthcare data. Tom, I'll come to you next.
I think we got to pick like what's the problem we most collectively can solve, and to me, selfishly as a parent, and I think selfishly to some of us follow. I think North Carolina is we have one of the worst infant mortality rates in the country. How do we tackle that? But how do we just agree to tackle that and put resources at a problem? And I think getting healthier kids and lower death rates is a good thing on the right to do. Otherwise, I think to me, something like food is medicine, which we've just applied for a grant to convene all the state entities. So Rebecca's probably going to chat with you about that. Is something like how do we do things together and scale? I think not to be like the capitalist person on the call, but I think we're spending a lot of money on administrative resources and maybe not as much money as we could on solving the problem. Because I think we all have slightly unique approaches to things, which is a good thing, and it's healthcare. So if anyone had the right answer, we'd already be doing it. So it's like I sort of appreciate there's like nuance to all of this. But I think there's going to take some humility on all of our parts to say, hey, this is 85% of what I want to do. But if we do it at a greater scale, we can touch more lives and improve the health of more people. And kind of going back to what Colleen said, food insecurity touches so many people in so many different ways and probably plays a significant role in mortality for mothers. So how do we, what is a problem we want to solve, but what is a root cause that can solve or tackle it? What is the root cause that can solve most problems? And also, the treasurer and I talk about it from an economic development perspective as well. Farmers in North Carolina are struggling too. Like agriculture is a big deal here for jobs. You hear a lot about AI taking a lot of jobs. It's not going to take farmer jobs, I hope, in the short term. So how do we invest in things we as a state do really well to solve our own problems and keep money in the state of North Carolina? I think is a pretty big opportunity, but some kind of lean into our strengths and some humility, I think is going to drive that bus best.
Yeah, really appreciate those points and focusing resources on root causes and coming together around that. Colleen, what would you add?
Yeah, I second everything that's been said. I do think though, as we look at some of the big initiatives that I think all agree are going to be needed to bend the cost curve, things like reducing avoidable utilization, improving care continuity, investing earlier, targeting those who need it most. I think the key takeaway, I think it's like a theme we're hearing throughout today, is that by addressing non-medical drivers of health, it's a way that we can actually make these more successful. Part of the challenge of reducing avoidable utilization is transportation gaps or food insecurity are often the reason people end up in the ER or back in the hospital. So by addressing these needs, it actually prevents that kind of high cost care before it happens, or it's a way that we can actually make care continuity possible. Value-based care arrangements and care management only work if people can actually access care and follow treatment plans and manage their chronic conditions. And we know some of these non-medical drivers of health can be a barrier that gets in the way of those being successful. So that, I think by investing in these kind of non-medical drivers of health, but integrating them into clinical care, making so it's not a add-on program, but it's actually integrated through financing, delivery, and technology, all the pieces that we heard earlier. I think that's what's going to make sure that we are really moving the needle on improving health, but also driving some sustainable solutions to make sure that we're actually driving down costs in the long term.
Yeah, I really appreciate that integrated point. And I think, a point that you were making, and Tom as well, is how does this really open the door for investment in other strategies and things that we as a state may want to prioritize, like farmers, like, value-based care arrangements is another strategy for reducing the cost curve. Rashina, you can close us out on kind of what would your top strategies or consensus areas for working toward a whole state strategy for bending the cost curve.
Yeah, I really appreciate what everyone has already said so far, and I think I'll just emphasize that, Tom's point about humility is really, I think, important, because often we're doing things in slightly different ways. We're trying to address the same problem, but we can't even compare how we're doing them because we're not doing this systematically, and we're not constantly examining, does your approach, is it, targeting the same population in just as an effective way as my approach? Because we're not talking and we're not designing systems to support that coordination early on. And so this is, I think there's a lot of consensus around that, and operationalizing that through things like the Rural Health Transformation Program will be really exciting.
Absolutely agree. Well, thank you all so much for a great discussion and sort of visioning of where do we go from here, and what are some key strategies to focus on for that. I'm going to turn it back over to Mark, who's going to wrap up our panels and open up for the Q&A portion of our time together this afternoon. So Mark, over to you.
Well, thanks, Rebecca. And I want to thank all of our panelists for some really up-to-date and a diverse set of insights about these programs, what they've accomplished, and where we can go from here. It's clear from the panels that despite the best efforts before these programs started, from healthcare providers, from health plans, from community organizations, from people working hard in our government, medical, and social care programs, we weren't getting to where we needed to be, a financially sustainable healthcare system that really helps people live healthier lives and not only bend the cost curve, but bend the chronic illness curve. And so it's clear from the panels that addressing non-medical drivers of health can make a difference in regard to both outcomes and costs, particularly when we can use better and better data, better insights, better teamwork across these different parts of our healthcare and health ecosystem that just hadn't been getting as much support as we could to enable them to work together better on behalf of the people in our communities. The first panel made clear that a significant focus of the ILD opportunities pilots was on building the infrastructure to enable that. New referral pathways, new data systems, new cross-sector partnerships, just the payment lining up with better health was important, but you needed infrastructure for that too. The second panel showed how this infrastructure is continuing to be built upon, is continuing to get better, get ongoing improvements to help reduce friction, to help find what's really working best for particular people's families and communities, to streamline operations, to better align the incentives and payment supports across these different sectors, healthcare, social, payers. A key theme across all of these panels, I think all of our panelists, was that no one can do this alone. This is not something that a problem that a single payer can solve. It's not something a government can solve by itself. It's not something that a community without the supporting resources can do. And that we can continually learn how to do it better. And this last panel, Colleen, Rashina, Laurie all highlighted ways in which this is happening in these programs now. Even during the pause in healthy opportunities, that's created some more innovations we just heard about too. I think Tom said it best. We are making progress, but we need to keep our humility around the need to make more progress, to iterate to do it better with more scale and also with improvements in data and our infrastructure. I think, Tom, this is one place where we do need AI and digital technology to help us be more productive. Models like HOP and INC demonstrate how bringing together these different resources can get us to more than the sum of the parts, and that working together and figuring out how to keep leveraging these limited resources is the path towards long-term viability beyond the initial pilots. So North Carolina is facing some real challenges today from a budget standpoint and a lot of needs around the states, but also seems very well positioned to continue to lead, just like the state's been doing before, in figuring out and implementing effectively the best way to get to the kind of sustainable healthcare system we need.